Welcome to the Rad-On Smart Review GU Cancer series.
Glad to be here for this one.
Yeah, so today we are exploring episode 21, Testicular Advanced Germ Cell Tumors, Residual Masses, and Salvage Strategy.
It is a really critical topic. I mean, we're leaving the simple stuff behind today.
Completely. We're leaving those basic stage I and II decision trees totally in the rearview mirror. This is where testicular cancer stops being a simple flowchart and, well, it becomes a really complex sequencing puzzle.
Right, exactly. Navigating risk classifications, figuring out chemo backbones,
Right.
and knowing exactly when a PET scan is useful or when it's actively dangerous to order one.
Oh yeah, the PET scan traps. And we'll get into the post-chemotherapy surgery stuff too, but to ground this, let's bring in our case anchor. I want you to picture a 32-year-old guy sitting in your exam room.
Okay, 32. Prime of his life.
Exactly. Previously totally healthy, but today he just looks exhausted. He's complaining of this progressive, really worsening low back pain that's waking him up at night. And he tells you he's dropped 20 pounds over the last few months without even trying.
Oof, that's a massive red flag right there.
Right. So you do the physical exam and you find a firm 5-centimeter left testicular mass.
And suddenly the back pain makes perfect, terrifying sense.
Exactly. So the pre-orchiectomy markers come back and they are sky high. I mean, we're talking an AFP of 4,200.
Wow.
Yeah. A beta HCG of 18,000, and his LDH is sitting at roughly 3 times the upper limit of normal.
Those are serious numbers.
Yeah.
That's a massive systemic tumor burden.
Yeah.
It's basically eating his body's energy reserves.
Literally acting like a parasite. So he gets the orchiectomy, and the pathology shows a mixed non-seminomatous germ cell tumor. It's got embryonal, yolk sac, mature teratoma, but the pathologist notes something crucial.
Let me guess. Absolutely no seminoma component.
Bingo. Absolutely no seminoma.
Okay, that locks us firmly into the non-seminoma pathway. The histology dictates everything from here on out.
Right. So we get the post-orchiectomy staging CT, and it shows a 6-centimeter retroperitoneal mass. Plus, he has bilateral lung nodules. The largest is about 2 centimeters.
But no liver, brain, or bone mets.
Nope. None of those. Scans for those are clear. So we fast forward just a bit. He's about to start chemo. It's day 1 of cycle 1, and they draw his markers again.
The pre-chemo baseline.
Right. His AFP is now 3:100, beta HCG is 14,000, and LDH is 2.8 times normal. And honestly, if I'm looking at those numbers, an AFP in the thousands, multiple bilateral lung mets, I'd be in full-blown panic mode.
Sure, it's totally overwhelming if you just look at the raw data.
Like, how do we not just treat this like an untreatable end-stage solid tumor?
Because advanced germ cell tumors are one of the greatest cure stories in oncology. I
Yeah.
mean, we cure the vast majority of these patients now, but you can't panic. You have to ground yourself in the IGCCCG framework.
The International Germ Cell Cancer Collaborative Group.
Yeah, it's a mouthful, but it is the absolute operating system for this disease. You cannot just treat this as stage 2 plus more.
Right. Anatomic stage doesn't drive the bus here.
Exactly. Treatment and prognosis are entirely governed by the IGCCCG risk classification. So we use a really simple mnemonic to keep the variables straight under pressure.
I love a good mnemonic. Let's lay it out for everyone. It's PVM, right?
PVM. So
Yeah.
P stands for primary site. You have to determine if the original tumor started in the testes, the retroperitoneum, or the mediastinum.
Okay, P is primary. And V.
V is for visceral metastases. But, and this is a huge one, it specifically refers to non-pulmonary visceral mets.
Okay, so liver, bone, brain.
Yes. Lungs do not count against you in the V category. And finally, M stands for markers.
Okay, PVM. But wait, I have to push back on the markers part right now.
Go for it.
Why are we using his day 1, cycle 1 markers for this calculation? His AFP was 3,100 on that day, but his peak pre-orchiectomy AFP was 4,200. Why don't we use the absolute highest number the tumor ever produced to judge how aggressive it is?
It's a great question, and it trips people up constantly. But the board rule is absolute here. The markers that matter are always the post-orchiectomy pre-chemotherapy numbers.
Even if they're lower?
Even if they're lower. Because think about the biology. That diseased testicle was a massive factory pumping out AFP and HCG into his blood.
Right, and we surgically remove the factory.
Exactly. Once that testicle is sitting in a pathology bucket, we don't care what it used to produce. We wait for the initial marker washout to settle, which takes a few weeks.
Because of the half-lives of the markers, right? Like AFP takes a week to have.
Spot on. So that day 1, cycle 1 blood draw tells us the true active baseline production of the remaining metastatic deposits. It tells you exactly the size of the enemy the chemotherapy actually has to fight.
Oh, that makes perfect sense. You want to measure the systemic burden that's left, not the ghost of the testicle.
Exactly. So let's look at the grand divergence in this framework. The IGCCCG treats non-seminoma and seminoma totally differently. Since our guy has non-seminoma, let's start there.
Okay, NSGCT. We have good, intermediate, and poor risk categories, right?
Yes. For good risk NSGCT, you have to hit a strict set of criteria. Primary site must be testes or retroperitoneum. Absolutely zero non-pulmonary visceral mets.
So no liver or brain mets.
Right. And all three of your markers must be in the lowest tier. So an AFP strictly under 1,000, beta HCG under 5,000, and LDH under 1.5 times normal.
Okay, and if they meet all that, they get 3 cycles of BEP. Bleomycin, etoposide, cisplatin.
Correct. But if they step up to intermediate risk, NSGCT, meaning the primary site and visceral mets criteria are the same, but one or more markers falls into the intermediate range, the treatment intensifies.
Because the burden is higher.
Yeah, exactly. Intermediate means AFP between 1,000 and 10,000, or HCG between 5,000 and 50,000. For them, we add a 4th cycle. Standard is 4 cycles of BEP.
Got it. And what throws a patient into the poor risk category?
A few things. If their markers are through the roof, AFP over 10,000 or HCG over 50,000, or if they have any non-pulmonary visceral mets, like a single liver met makes them poor risk immediately.
Even if the markers are low.
Yep. And here is a crucial pearl. A mediastinal primary NSGCT is automatically poor risk.
Wait, really? Just based on the location in the chest? Why is that?
It's fascinating biology. Germ cells that get stranded in the mediastinum during fetal development are genetically volatile. When they turn into non-seminoma, they are inherently highly resistant to platinum chemo.
Wow, so they just don't respond well to the BEP.
They don't. And worse, they have a notorious tendency to undergo somatic-type malignant transformation. They literally mutate into completely different aggressive non-germ cell cancers like sarcomas or leukemias.
That is terrifying. So mediastinal primary equals automatic poor risk.
Always. And standard frontline for poor risk is also 4 cycles of BEP, though it's worth noting the bleomycin substitutes.
Right. If a patient has bad lungs and can't get bleomycin, what do we give them?
For intermediate or poor risk, the bleo-free substitute is 4 cycles of VIP. That's etoposide, ifosfamide, and cisplatin. You need the ifosfamide to maintain the cytotoxic intensity.
And for good risk?
For good risk, the substitute is just 4 cycles of EP, no ifosfamide needed.
That's a perfect board distinction. EP for good risk, VIP for intermediate or poor risk.
Okay, so that's the non-seminoma framework. What about pure seminoma?
This is where people fall into traps. The most unbending rule for advanced pure seminoma is this. There is absolutely no poor risk category.
Wait, none at all, even if they have a massive 15-centimeter tumor wrapping around their aorta.
Doesn't matter. Seminoma is so exquisitely sensitive to platinum chemo that even massive bulky disease melts away. You are either good risk or you are intermediate risk. That's it.
Okay, so how do you define good risk seminoma then?
It's surprisingly simple. No non-pulmonary visceral mets. And your AFP must be totally normal. Your beta HCG or LDH can be elevated to literally any theoretical number, and you're still good risk.
That's crazy. And treatment is 3 cycles of BEP.
Yep, 3 cycles of BEP.
So what makes a seminoma intermediate risk?
The sole trigger is the presence of non-pulmonary visceral metastases. So spread to the liver, bone, or brain, that bumps them to intermediate risk, and they get 4 cycles of BEP. Let me clarify this because it feels like a trick. Say you have a patient, stage IC pure seminoma, huge, bulky retroperitoneal adenopathy, but no liver or lung mets. Is this intermediate risk because it's stage IC and the tumor is huge?
No. Without visceral mets, it is definitively good risk seminoma. Do not let anatomic bulk fool you.
That is such a classic trap. Now, what about that AFP rule you mentioned? You said AFP must be normal in seminoma. Why can HCG be high, but AFP has to be normal?
It comes down to the cells. About 10 to 15% of pure seminomas naturally contain syncytiotrophoblastic giant cells. Those are the cells that make beta HCG.
Oh, right. Like in a placenta.
Exactly. So an elevated HCG is totally expected, but AFP is strictly produced by yolk sac or embryonal elements. Those are non-seminoma cells. Pure seminoma physically cannot make AFP.
So if I'm looking at a pathology slide that says 100% pure seminoma, but the patient's blood test shows an AFP of 200, who wins? The slide or the blood?
The blood test wins every single time.
Really? You just assume the pathologist missed something.
Yes. You have to assume there's a hidden microscopic pocket of non-seminoma in that tumor that the biopsy needle or the blade just missed. You must treat them using the more aggressive NSGCT framework.
If you don't, you'll undertreat those hidden elements and they'll relapse.
Exactly. Okay, so let's apply all this to our 32-year-old case
All
patient.
right, he has a mixed NSGCT in the testes, lung mets, but no non-pulmonary visceral mets. His day one, cycle one markers are AFP 3100 and HCG 14,000.
So we use PVM. Primary site is testes. That's good risk. Visceral mets, he only has lung, so that's also good risk. But the markers.
His AFP and HCG are both sitting right in that intermediate range.
Exactly. And since you only need one factor to upstage the risk, he is definitively an intermediate risk NSGCT patient. And his standard frontline treatment is 4 cycles of BEP. Boom, we solved the first part of the puzzle.
We did. But before we actually drip the chemo into his veins, we have to run the workup checklist. Right, because rushing to chemo without checking the boxes is a disaster. CT of the chest, abdomen, pelvis done. Day one, cycle one markers done. We need baseline renal and pulmonary assessments, right?
Absolutely.
Yeah.
Because cisplatin causes acute nephrotoxicity. It accumulates in the proximal tubules of the kidneys, so we need a baseline creatinine clearance.
And pulmonary function tests for the bleomycin.
Yeah, specifically looking at the DLCO. Bleomycin generates massive oxygen-free radicals. The lungs lack the enzyme to neutralize it, so it can cause severe interstitial pneumonitis. We need to know his lungs can take the hit.
Makes total sense. But there's another really personal conversation we have to have here. He's 32 years old. Before we start this highly toxic chemo, we must talk about fertility.
Yes, it is non-negotiable. Mandatory fertility counseling and sperm banking before chemo starts. Cisplatin is highly gonadotoxic. After 4 cycles of BEP, most of these men will have profound oligospermia or be totally azoospermic.
Meaning they're producing basically zero viable sperm.
Exactly. Sometimes it recovers after a few years, but often the damage is permanent. You must forcefully advocate for sperm banking before the first drop of chemo. If you forget, you were failing their long-term survivorship.
Yeah, you're treating the cancer, but ruining their chance at a future family.
Okay, what about a brain MRI? Do we need to scan his head before chemo?
Not routinely for everyone, but it's highly recommended if they have high-risk features, like obviously if they have headaches or vision changes.
Right, symptomatic is obvious. What about asymptomatic?
You'd consider an MRI if they have markedly elevated beta-HCG, usually over 5,000 or 10,000, or massive pulmonary mets, or poor-risk NSGCT.
Well, our guy's HCG is 14,000, and he has multiple bilateral lung nodules.
Exactly. So ordering a brain MRI here is absolutely reasonable to rule out occult CNS disease.
Okay, one more staging question.
Okay.
Residents love to ask this. Should we get a baseline FDG-PT scan just to see the full metabolic extent of the disease before we start?
Absolutely not. Do not do it.
So no baseline PUT scan. Never. P has absolutely no role in the initial staging of a germ cell tumor. High-quality CTs and markers give you 100% of the information you need.
So a P scan just adds confusion.
It adds confusion, false positives from benign inflammation, it wastes resources, and it delays the start of urgent chemo. If you order a staging PET on the oral boards, you are loudly telegraphing that you don't know the guidelines.
Okay, loud and clear. No PET. So our patient banks his sperm, his brain MRI is clear, and he powers through his 4 cycles of BEP.
Which is brutal, but he makes it.
Yeah. But honestly, giving the chemo isn't the hardest part of managing these patients. The hardest part, where tumor boards turn into shouting matches, is interpreting the post-chemo scans.
Without a doubt. This is where the algorithms for seminoma and non-seminoma violently diverge. If you mix them up, you will make a catastrophic error.
Okay, let's break it down. Cycle 4 is done. We wait a few weeks and we rescan him. His markers have completely normalized. AFP, HCG, LDH, all back to normal.
Yeah.
But on the CT, there's a visible lump right there in the retroperitoneum where the original mass was.
The classic residual mass.
Right. Let's pretend for a minute our patient had a pure seminoma. How does the seminoma algorithm handle a residual mass with normal markers?
For seminoma, everything is dictated by the physical size of that residual mass on the CT. The magic, guideline-defined cutoff is 3 centimeters.
3 centimeters. Got it.
If the mass is strictly under 3 centimeters, standard of care is active surveillance. You just watch it.
You don't biopsy it or take it out.
No. The vast majority of these sub-3 centimeter blips in seminoma are just dead fibrotic scar tissue or necrotic debris. The risk of viable tumor is incredibly low.
Okay, but what if the mass is 3 centimeters or larger?
That is the specific scenario where FDG-PET finally enters the chat. For a mass 3 centimeters or greater, you get a PET scan. But there is a massive caveat.
Let me guess, you can't just do it right away.
Right. You must delay the PE scan. You have to wait at least 6 weeks, ideally 8 weeks, after the last day of chemotherapy before you scan them.
And why the delay? Why not scan them at 1 or 2?
Inflammation. As the chemo kills the massive tumor, your immune system sends macrophages to clean up the dead cellular debris. Those macrophages consume a ton of glucose.
Oh, so they'll suck up the radioactive FDG tracer.
Exactly. If you scan at week 2, the mass will light up like a Christmas tree, and you'll think it's raging cancer, but it's really just your body healing. You have to wait 6 to 8 weeks for the biological dust to settle.
That makes perfect sense. Now, waiting for that delayed PET scan feels a bit like staring at the check engine light on your dashboard.
I love that analogy. It's totally true.
Because it's an asymmetric test, right? Think about your car. If the check engine light is off, meaning the PET scan is negative, you're highly reassured. The engine is fine, the chemo worked, you can confidently put the patient on surveillance.
Right. The negative predictive value is excellent.
But if the check engine light turns red, if the PE scan is glowing hot over that residual mass, it's not proof that your engine just exploded. It's not a death sentence.
Exactly. It's not proof of viable tumor. It very often just reflects a smoldering pocket of persistent sterile inflammation. It just means you need to look closer.
You don't just blindly throw a brand new engine into the car because the light came on.
Right. You open the hood. In clinical terms, you don't reflexively order toxic salvage, chemo, or massive surgery just because of one glowing scan. You repeat the scan in a month, or you present it at tumor board, or most definitively, you do a needle biopsy.
You demand tissue proof before you do anything drastic.
Exactly. Only if the biopsy proves there is viable seminoma do you initiate salvage treatment.
Okay, so that's the seminoma rule. 3 centimeters is the threshold, delayed PET scan is the tool, and a positive PE requires caution, not a reflex reaction.
Perfectly summarized.
But let's snap back to our actual 32-year-old patient. He doesn't have seminoma. He has a mixed non-seminomatous germ cell tumor, embryonal yolk sac, mature teratoma. How does this algorithm change for him?
It flips 100% upside down.
Yeah.
For NSGCT residual masses, PET scans are essentially completely useless. We do not use them.
Wait, not at all.
Not at all. And the reason we violently discard the PET scan here comes down to one specific, stubborn biological entity, the teratoma problem.
Teratoma, the unique villain of the non-seminoma story. Explain mechanically why teratoma is such a nightmare to manage.
All about the histology. Teratoma is composed of mature, highly differentiated somatic tissues from different embryonic layers.
Right, so under a microscope, you're not just looking at generic cancer cells, you're seeing fully formed mature cartilage or disorganized bone tissue or muscle fibers.
Yeah, exactly. And because these constituent cells are highly mature, they have a very low mitotic rate. They aren't rapidly dividing.
And chemotherapy targets rapidly dividing DNA.
Bingo. So standard chemo, like cisplatin, basically does nothing to these mature cells.
Mm-hmm.
Teratoma is, for all intents and purposes, entirely chemo-resistant.
It just sits there in the retroperitoneum, completely ignoring the chemo that's killing the rest of the embryonal cells.
Yes. And further, because it's mature, low metabolic tissue, it doesn't reliably take up the FDG glucose tracer on a PET scan. A PET scan of pure teratoma will often come back completely falsely negative.
It'll tell you it's dead scar tissue, but it's actually chemo-resistant teratoma.
Exactly why PET is biologically useless here.
But let me play devil's advocate. If it's just slow-growing cartilage or disorganized bone, why do we even care? If the aggressive cancer is dead, why not just leave the harmless lump of cartilage inside the patient?
Because it is absolutely not harmless. We can't leave it for 2 deeply dangerous reasons. First, teratoma can continuously enlarge over time. This is called growing teratoma syndrome.
So it acts like a slow-moving boulder in the abdomen.
Exactly. It can mechanically compress and obstruct vital structures. It can crush the ureters and cause kidney failure, or compress the inferior vena cava.
Okay, so physical compression. What's the second reason?
Malignant transformation. These benign-appearing teratoma cells harbor a latent, terrifying potential to mutate into completely non-germ cell malignancies later in life.
Oh, wow.
Yeah, a teratoma left behind can transform a decade later into a deadly sarcoma or an aggressive adenocarcinoma. And those transformed tumors are completely immune to standard germ cell chemo. They are devastatingly difficult to cure.
So intentionally leaving teratoma behind is basically leaving a biological time bomb in their abdomen.
Literally. Which brings us to the absolute cardinal rule of non-seminoma post-chemo management.
Let's hear the rule. What's the size threshold?
If an NSGCT patient finishes frontline chemo, markers completely normalize, and the follow-up CT shows a residual mass measuring 1 centimeter or larger in any single dimension, the unquestioned standard of care is aggressive surgical resection.
1 centimeter. That is so small.
It is. But you must perform a post-chemotherapy RPLND, a retroperitoneal lymph node dissection, at a specialized high-volume center.
I have to push back here again, putting myself in the patient's shoes. I just went through 12 brutal weeks of BEP. I lost my hair. I was violently nauseous. You tell me my markers are perfectly normal. But you see a tiny 1.2 centimeter blip on the CT. You want to slice my abdomen wide open from sternum to pubis for a massive vascular surgery. Couldn't that tiny blip just be scar tissue? Do we really have to do this?
It's an incredibly emotional conversation, but the medical answer is a firm yes. And here's how you explain it to the patient. Modern imaging CT, MRI, PET simply cannot differentiate between three distinct possibilities inside that tiny mass.
Okay, what are the three possibilities?
Possibility one.
Yeah.
Or roughly 40 to 50% of the time, it's indeed just harmless necrosis and scar tissue.
So surgery wouldn't technically be needed.
Right. But possibility two, roughly 40 to 50% of the time, it is teratoma, which is that ticking time bomb we just talked about.
And possibility three.
In roughly 10 to 15% of cases, that mass actually still harbors viable, actively dividing non-teratomatous cancer cells that stubbornly survive the chemo.
Ah. And because imaging is totally blind to which of those three it is, you have to get the tissue out.
Exactly. Surgery owns this clinical problem. Getting the tissue out and onto a pathologist's slide is the only safe, definitive path to guarantee a cure.
Undeniable logic. So our case patient, his CT comes back. Markers are normal, but he has a 2.2 centimeter residual mass. He's unequivocally heading for an RPLND.
Yes, he is. And I must emphasize it has to be at a high-volume tertiary care center. A post-chemo RPLND is a vastly more dangerous beast than a primary RPLND done before chemo.
Why is it so much more dangerous? What does the chemo do to the anatomy?
It induces this intense desmoplastic reaction. When that massive original tumor dies, it triggers a severe fibrotic healing response. This massive scarring effectively glues the residual lymph nodes tightly to the vital retroperitoneal structures.
The aorta, the inferior vena cava.
Yeah, the lumbar vessels. It literally turns the retroperitoneal anatomy into concrete. The normal surgical planes are completely obliterated. It's highly technical, and often surgeons have to do an en bloc resection, occasionally even resecting a portion of the vena cava just to get the tumor out completely.
Wow. And beyond the massive vascular risk, there's a huge quality of life concern here for these young guys. The preservation of ejaculatory function.
Oh, definitely. The delicate, sympathetic nerve chains that control antegrade ejaculation run right alongside, and sometimes weave intricately through those lymph nodes around the aorta and vena cava.
So specifically, the postganglionic sympathetic fibers from T10 to L2, they control the contraction of the vas deferens and bladder neck closure during climax.
Exactly. And during this extensive dissection, those microscopic nerves are at extremely high risk of being severed. If they're cut, the bladder neck fails to close, and the patient develops retrograde ejaculation, or complete anejaculation.
Which renders them infertile via normal intercourse.
Right. Which is yet another reason high-volume centers are mandatory. An expert urologic oncologist will meticulously attempt a nerve-sparing technique provided, and this is the non-negotiable caveat, provided that sparing the nerves does not compromise the oncologic completeness of the surgery.
Because curing the cancer always comes first.
Always.
Okay, so he undergoes the open RPLND. The expert surgeon clears out the retroperitoneum, hopefully spares the nerves, and sends the specimen to pathology. How does the final pathology report dictate the rest of his life?
It all hinges on what the pathologist sees. There are three potential outcomes, mirroring those three possibilities. Outcome one, the mass is entirely dead, necrosis and scar tissue.
Which is the dream scenario. The BEP chemo killed everything.
Exactly. No further treatment needed. He goes on routine surveillance. Outcome two, the pathologist finds mature teratoma, but confirms it's been cleanly resected with negative margins.
So the surgery did its job, diffused the time bomb.
Yeah. And he also generally transitions to surveillance. But outcome three is the dangerous one. What if the pathologist finds viable, actively dividing non-teratomous cells, actual embryonal or yolk sac cells that survived the chemo?
Meaning the frontline chemo just wasn't enough?
Right. If viable tumor is found, he is at significant risk of systemic relapse. In this situation, the recommendation is typically additional systemic therapy, often 2 more intensive cycles of EP, TIP, or VIP to wipe out any microscopic disease left.
Though that's a complex tumor board decision, right? Weighing how much viable tumor was found against his ability to tolerate more chemo right after a massive surgery.
Exactly. Highly individualized at that point.
Okay, so that perfectly covers the standard frontline sequence. Orchiectomy, proper staging using day 1 cycle 1 markers, PVM mnemonic, categorized as intermediate risk NSGCT, 4 cycles of BEP, normalized markers, 2.2 centimeter mass, post-chemo RPLND, and most patients do phenomenally well after that.
They really do. They're effectively cured.
But, we have to talk about salvage strategy. What happens if the patient relapses down the road? And seriously, as radiation oncologist hosting this, I've been waiting patiently. When do we actually get to use our linear accelerators?
Huh. It is a completely fair question. I promise I will clearly outline the narrow lane for radiation. But let's tackle relapse timing first, because the calendar changes everything. Is it an early relapse or a late relapse?
Okay, define the timeline. What's early?
Early relapse is strictly defined as a recurrence within 2 years of completing the frontline cisplatin-based chemo.
Okay, so 8 months later, his AFP starts steadily rising, or a new lung met appears.
Right. We interpret that biologically as a failure of the initial chemotherapy to completely eradicate the microscopic disease. It was suppressed, but not destroyed. So the logical approach is to treat it as a systemic problem with aggressive salvage chemotherapy.
But we can't just give BEP again, right? Those cells already proved they can survive it.
Correct. We use standard dose salvage regimens with entirely different, theoretically non-cross-resistant drugs, like the TIP-E regimen paclitaxel, ifosfamide, and cisplatin, or VIP vinblastine, ifosfamide, cisplatin. We want to hit them with unfamiliar pharmacological mechanisms.
And what if that doesn't work, or if it's a super high-risk early relapse?
Then specialized centers escalate to high-dose chemotherapy combined with autologous stem cell support.
Let's talk about the mechanics of stem cell rescue, because it's wild. Germ cell tumors have a steep dose-response curve, meaning higher doses kill more cancer cells.
But if we just gave massive, ultra-high doses of chemo, we would permanently destroy the patient's bone marrow. They'd die of profound immunosuppression.
Yeah, right. So we bypass that limit. We extract and harvest the patient's healthy stem cells from their blood, freeze them, and then we nuke the patient with astronomically high, intentionally lethal doses of chemo.
Exactly. Doses high enough to kill the resistant cancer cells. And after the chemo clears their system, we thaw their healthy stem cells, transfuse them back in, and they home back to the marrow cavity to rescue the patient from certain death.
It's an incredible brute force feat of medical engineering. So that's early relapse, a systemic problem needing a systemic solution. But what about a late relapse, say 5 or 10 years later?
A late relapse, defined as occurring more than 2 full years after finishing treatment, is a totally different biological animal. And this is a massive, absolute board pearl.
Let's hear it.
For a late relapse of a non-seminomatous germ cell tumor, if the disease is anatomically localized and resectable, you must immediately think surgery first.
Surgery first. Why the sudden shift away from systemic chemo?
Evolutionary pressure.
Yeah.
The frontline BEP killed all the sensitive cells years ago. The rare cells that survived and insidiously grew back over 5 years are almost universally profoundly chemoresistant. Often it's pure teratoma or malignant transformation.
So throwing more chemo at it is basically useless.
Exactly. It's largely ineffective and just gives them severe toxicity. So if it's resectable, like an isolated retroperitoneal node or a solitary lung nodule aggressive surgical extirpation, offers the only realistic chance of a true cure. You cut out the resistant armor.
That is elegant biology. But wait, you qualified that rule specifically for late relapse non-seminoma. What if a pure seminoma relapses 5 years later?
Seminoma is biologically distinct again. Late relapsing seminoma is rare, but when it happens, it often stubbornly retains its inherent sensitivity to platinum chemo and radiation therapy. So the rigid surgery first reflex doesn't automatically apply.
Which means the radiation oncologist officially enters the chat.
Yes, finally.
Right.
But let's be incredibly precise here, because on oral boards, residents love to just blurt out, and then I would radiate it, like it's a magic wand.
Oh, I've seen it.
So let me state explicitly where radiation does not fit. It has absolutely no routine frontline role in metastatic NSGCT, and it is absolutely not the standard answer for managing a post-chemo NSGCT residual mass.
Right. If there's a 2-centimeter mass left over after chemo, you do not radiate it, you cut it out because of the teratoma risk. So where's our specific lane?
There are 2 main settings for radiation in advanced disease. First, in highly selected cases of localized, viable seminoma post-chemotherapy.
Give me a scenario.
Say a patient has pure seminoma, 4-centimeter residual mass after BEP. We waited 8 weeks, the delayed PT scan was blazing hot, and a biopsy proved it was viable, recurrent seminoma. Usually you'd consider salvage chemo, but let's say it's purely localized to that single node. and the surgeons say an operation is technically unfeasible or excessively morbid due to dense desmoplasia encasing the aorta.
Okay, so surgery is out.
Right. In that highly specific localized salvage scenario, where surgery is unsafe but you desperately want local control, radiation therapy is an excellent option because seminoma is exquisitely radiosensitive.
So localized salvage for seminoma only when surgery is unfeasible. That's a huge critical distinction. What's the second lane?
The multimodality management of brain metastases. The central nervous system is a pharmacological sanctuary site. Many chemo drugs don't cross the blood-brain barrier efficiently.
And brain mets happen more often in those poor-risk NSGCT patients with crazy high HCCG levels, right?
Exactly. So systemic chemo is still the foundation, but radiation therapy, usually delivered as highly precise stereotactic radiosurgery, or SBRT, targeted to individual brain lesions or occasionally whole brain radiation if there are numerous mets, is very often used alongside chemo to ensure durable local control in the brain.
Okay, so the bulletproof way to frame this on boards is radiation has a highly selective role. It's not routine for frontline NSGCT or post-chemo residual masses, but I'd consider it for localized salvage and seminoma when surgery is unfeasible or in multimodality management of CNS metastases.
If you say exactly that to an examiner, they will nod and move to the next question.
Perfect. Okay, we've talked a ton about the mechanics, pharmacology, and surgery to cure the patient, but we need dedicated time to talk about what happens after the cure. Survivorship.
It is arguably just as important as knowing the chemo regimens. These are young men in their 20s and 30s. We cure over 80% of them, which means they're going to live with the physical consequences of our toxic treatments for 40, 50, maybe 60 years.
Survivorship is a lifelong commitment here. Let's break down the toxicities. Short-term hits from the frontline chemo first. Cisplatin is the heavy hitter.
It's the platinum backbone. It cross-links the DNA to trigger apoptosis, but it is brutal. Short-term, it causes severe nausea and vomiting. Even with modern antianics, it's rough. And as we mentioned, it causes significant acute nephrotoxicity, requiring massive IV hydration protocols.
And then there's the permanent neurological and auditory damage. How does that happen?
Cisplatin can permanently damage peripheral nerves, leading to a classic stocking glove sensory neuropathy. Chronic numbness, tingling, debilitating pain in the hands and feet. It affects their ability to type, walk, work.
And the hearing loss.
It physically damages the delicate outer hair cells in the cochlea. This leads to high-frequency hearing loss and persistent, maddening tinnitus. Sometimes it's reversible, but very often it's a permanent disability.
That is just heartbreaking. Now, what about bleomycin? We touched on the pulmonary toxicity, the interstitial pneumonitis, but I want to talk about the surgical implications of it.
Yes, this is a vital, life-saving clinical pearl, especially since so many of these patients will eventually need an RPL&D.
It's the interaction with oxygen during anesthesia. Right, let's explain that mechanically.
Remember that bleomycin generates oxygen-free radicals to cleave DNA. Even months or years after chemo ends, there's latent subclinical damage in the lung tissue. If that patient goes into the OR and the anesthesiologist gives them high concentrations of inspired oxygen, a high FiO2 during general anesthesia.
It provides the exact fuel to restart that free radical cascade.
Exactly. It can precipitate an acute, severe, often fatal postoperative pulmonary crisis, or ARDS. The anesthesiologist absolutely must know the patient had bleomycin. They must strictly keep intraoperative oxygen levels as low as safely possible, often maintaining O2 saturations just in the low 90s, and strictly manage fluids.
It's fascinating but terrifying. So those are the subacute hits. What about the true long-term survivorship issues 20 years down the line?
The data is sobering. First, extremely high risk of hypogonadism. Between the orchiectomy and the gonadotoxic chemo, many inevitably develop premature testosterone deficiency, low libido, chronic fatigue, muscle loss. Many need lifelong testosterone replacement injections just to maintain baseline quality of life.
And there's a big cardiovascular component too.
Significant risk of cardiovascular disease. Long-term survivors of platinum chemo have much higher rates of metabolic syndrome, severe hypertension, hyperlipidemia, early onset obesity, and a prematurely increased risk of severe coronary artery disease and heart attacks.
Do we know why?
It could be direct endothelial damage from the heavy metal cisplatin in their blood, or secondary to the chemo-induced hypogonadism, but the risk is real and needs aggressive primary care monitoring.
So you really can't just discharge them from the clinic after 5 years and say, have a nice life, you're cured.
You absolutely cannot. And perhaps most worryingly, they carry a substantially increased risk of developing second malignant neoplasms later in life.
From the treatments themselves.
Yes, etoposide carries a known risk of triggering secondary hematologic malignancies, specifically acute myeloid leukemia. And if they ever received radiation therapy, they have an increased risk of secondary solid tumors like sarcomas or GI cancers emerging 15 or 20 years later directly in the radiation field.
This is exactly why the field is obsessively trying to safely de-escalate therapy. We want to cure them with the absolute bare minimum toxicity possible.
The dominant trend is strictly risk-adapted, no more than necessary treatment.
And this ties directly into how you communicate with them. If you're sitting across from a terrified 32-year-old, you cannot be falsely breezy. Don't just say, it's just a few months of chemo and you'll be completely back to normal.
Because the biological truth is, he might never be completely back to normal.
Right. He might have ringing ears forever. He might need testosterone injections weekly. He might have numb toes. You have to look them in the eye and say, we have a highly effective plan to cure this, but surveillance and survivorship care are mandatory lifelong commitments. We're in this for the long haul.
Honesty about the physical reality builds the trust required for decades of follow-up.
Okay, we have covered an immense amount of ground today. The IGC-CCG risk groups, the teratoma problem, salvage strategies, survivorship. To make sure these dense sequencing rules are totally locked in, let's run through a rapid-fire board review.
Let's do it.
We call this the board blitz. 4 quick, classic oral board trap scenarios. You give the definitive textbook answer and the why. Ready?
I am ready.
Blitz scenario 1. The NSGCT post-chemo rule. 28-year-old male, intermediate risk NSGCT. Completes 4 cycles of frontline BEP. Tumor markers perfectly normalized. Restaging CT shows a 2.2 centimeter residual retroperitoneal mass. What is the single best guideline-supported next step? A. FDG PET scan. B. Active surveillance. C. Post-chemotherapy RPLND. Or D. Radiation therapy.
The absolute best answer is C, post-chemotherapy RPLND at a high-volume center. In non-seminoma, any residual mass 1 centimeter or larger with normal markers dictates immediate surgery. You do not order a PT scan because it can detect chemo-resistant teratoma. You must operate to prevent growing teratoma syndrome or malignant transformation.
Perfect. Blitz scenario 2. The seminoma staging trap. 36-year-old man, 100% pure seminoma on pathology. Staging CT shows massive, bulky 8 centimeter retroperitoneal adenopathy encasing the aorta. Chest CT is clear. No liver, bone, or brain mets. Normal AFP. Is this patient automatically classified as intermediate risk because his disease is stage IC and physically massive?
No, absolutely not. Classic trap. In advanced seminoma, there is no poor risk category, and intermediate risk is defined solely by the presence of non-pulmonary visceral metastases. Since he has no liver, bone, or brain mets, he remains firmly good risk, regardless of the bulky nodes. Standard good risk therapy, 3 cycles of BEP.
Exactly. Blitz scenario 3. The seminoma PET trap. Patient finishes chemo for advanced pure seminoma, markers normalize. Restaging CT shows a 5 centimeter residual mass. Because it's over the 3 centimeter threshold, you wait 8 weeks and order an FDG PET. The PET scan comes back positive, lighting up hot over the mass. Does this scan provide definitive proof of viable seminoma, and should you immediately start highly toxic salvage chemo?
No, it does not. A positive PET in post-chemo seminoma is an asymmetric test. It's just a warning light prompting further investigation. It's very often just persistent macrophage activity or sterile inflammation. You should repeat the scan later, do an image-guided biopsy, or initiate tumor board review. You'd never reflexively start salvage treatment based solely on one positive PE scan.
Spot on. Finally, Blitz scenario 4. The late relapse rule. Patient treated successfully for an NSGCT 5 years ago. On routine surveillance, presents with new pain. Imaging reveals an isolated 3 centimeter retroperitoneal mass. Serum markers are completely normal. The CT confirms it's anatomically resectable. What is the classic board move for the specific late presentation?
The classic move is surgery first. This is a late relapse of a non-seminoma. Because it's more than 2 years after the initial chemo, the biology is presumed to be highly chemo-resistant, often pure teratoma or malignant transformation. Since it's localized and resectable, immediate surgical extirpation is the most appropriate first step, rather than useless salvage chemo.
Flawless breakdown. Let's bring this all together. We started by stating that advanced testicular cancer is a complex sequencing puzzle. The foundation is the IGCCCG. You absolutely have to use the correct temporal markers, the post-orchiectomy pre-chemotherapy numbers. Remember, PVM primary site, visceral mets, markers.
And never confuse anatomical stage with the biological risk group, especially in seminoma where there's no poor risk category. Bulky retroperitoneal disease is still good risk if there are no non-pulmonary visceral mats.
Right. And once frontline chemo is done, firmly separate your seminoma and non-seminoma residual mass algorithms. For seminoma, the threshold is 3 centimeters, and you use the delayed PE scan, but respect the asymmetry of that test.
Whereas for non-seminoma, PE is completely useless. The threshold is 1 centimeter. If markers are normal and a mass of 1 centimeter or greater remains, surgery is king because of the teratoma risk.
And finally, for recurrences, remember the late relapse, surgery first reflex for non-seminoma. Cut out the chemo-resistant armor. If you can articulate these distinctions confidently, you will sound incredibly safe and undeniably correct.
The intricate sequencing really makes sense once you understand the underlying embryology, pharmacology, and biology driving the disease.
I completely agree. We've covered frontline treatments and salvage strategies today, but in our very next session, we are shifting focus entirely. We will dive directly into the deep end of survivorship. The exact surveillance schedules, the psychological impact on fertility, managing hypogonadism, and monitoring for those decades-later treatment effects.
It's an absolutely essential discussion for anyone who actually cares for these patients over the long term, rather than just treating this scan.
I am really looking forward to it. Just remember the core lesson today. You aren't just looking at random gray shapes on those post-chemo scans. You are looking at the biological history of the tumor. Hunt down the teratoma in non-seminoma, respect the PET in seminoma, and you will guide these young men to a cure. Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.